Hello everyone and welcome to our module on ear infections and fever. Let's start by talking about otitis media, which is an acute infection of the middle ear that is very common in the pediatric population. If you look at this drawing on the screen, this is the ear, this is the outer ear, here's the tympanic membrane, and this is the inner ear in this portion here behind the tympanic membrane, including the eustachian tube here. Otitis media usually is preceded by a viral upper respiratory tract infection. Viral URIs cause edema and swelling in the outflow portion of the eustachian tube, and this obstructs eustachian tube drainage. As a result, bacteria in the upper respiratory tract can enter the middle ear and colonize it, and microbial growth occurs, and that's what leads to otitis media. And what this means clinically is children who develop otitis media, usually before they develop the ear symptoms, have a couple of days of a runny nose or a cough or some other type of viral upper respiratory infection symptoms. The majority of cases of otitis media are caused by three bacteria. The first one is strep pneumo. The second one is H. influenza, so-called non-typable H. influenza. And what this means is not H. influenza type B, for which there is a vaccine. And I talk about that in the module on vaccinations. And then the third bacteria is Moraxella catarrhalis. The most common complaint among children who have otitis media is ear pain. This is almost always present. In up to 2/3 of cases, there's a fever, and then usually that's all most children have is a fever and ear pain, but some children will have some type of hearing loss, and occasionally children will note some drainage from the ear. Otitis media is a clinical diagnosis. You can make the diagnosis by examining the tympanic membrane in a child who has ear pain. To make the diagnosis of otitis media, you must see evidence of a middle ear effusion, meaning fluid behind the tympanic membrane, plus signs of middle ear inflammation. This could be something like the tympanic membrane being erythematous, or it could be fever in the child or ear pain in the child. If you see a middle ear effusion but there's no evidence of inflammation, meaning no ear pain, no fever, no redness of the tympanic membrane, then the diagnosis is otitis media with effusion, which we'll talk about later in this video. To diagnose infectious otitis media, you must see evidence of middle ear inflammation. And a classic sign of middle ear inflammation is bulging of the tympanic membrane. This is the most specific sign of acute inflammation of the middle ear, and that's what's shown in this picture here. So this is the tympanic membrane. You can see there's white pus behind it, and it's bulging out. This is about as classic as it gets for a tympanic membrane in a child with otitis media. Shown on this slide are the indications for treatment with antibiotics in otitis media. First of all adults should get treated. Otitis media is much less common in adults than children, but when adults do get this infection, they should receive antibiotics. Children under 2 years old are always treated, and children over 2 are treated if they have certain features. One of those features is a toxic appearance. This refers to a child who is lethargic or not eating well and looks very sick. Another indication for antibiotic treatment in a child over 2 is temperature that's higher than 102.2 or more than 48 hours of ear pain. And many children who develop otitis media have one of these three features, so children are often treated with antibiotics. But you should be aware that according to guidelines, if children are over 2 years old and their symptoms are mild and they don't have any of these features, you can potentially observe them. And the reason for this is because many of these cases will resolve on their own, and the more we use antibiotics, the more likely children are to get antibiotic-resistant infections. The first-line therapy for children with otitis media is the antibiotic amoxicillin, which covers those three bacteria we talked about a few slides ago. In special cases, the broader spectrum antibiotic amoxicillin clavulanate is sometimes used. This is done when there's a high likelihood of antibiotic-resistant bacteria being present. So the typical indications are a child who has recurrent acute otitis media. Another indication is a child who's recently been treated with a beta-lactam antibiotic and therefore may have resistant bacteria present. The advantage of amoxicillin clavulanate is it covers some strains of H. influenza that are resistant to amoxicillin. These strains are a common cause of antibiotic failure when amoxicillin alone is used. And then for children who develop recurrent otitis media, surgical therapy is often used, so let's talk about that now. A myringotomy is a surgical incision placed in the tympanic membrane, and this is a minor surgical procedure that can be done in children who have recurrent ear infections. This is beneficial to the child for a couple of reasons. First of all, it prevents negative pressure from developing in the eustachian tube. If we go back to this slide, when the eustachian tube here doesn't drain normally because of inflammation and swelling, there can actually be a negative pressure created within the middle ear that sucks in bacteria and other cells from the respiratory tree, and this can lead to recurrent otitis media. So by putting a little hole in the tympanic membrane, that negative pressure situation can never occur. A hole in the tympanic membrane also allows drainage of fluids, and it also allows topical antibiotics to be placed directly into the middle ear. Now, the problem with a myringotomy is that perforations in the tympanic membrane usually close rapidly. So for this reason, most children who have a myringotomy also have tympanostomy tubes placed. This is a picture of what one of these tubes looks like shown on the screen here. These are straight, narrow polymer tubes that can remain in the ear for several months and keep that opening between the outer and inner ear present. And this is done for children who have recurrent otitis media. Let's talk about some of the potential complications of otitis media. First of all, the tympanic membrane can perforate from otitis media itself. This will allow some of the fluid out, but this is obviously damage to the membrane that has to heal. Another complication is mastoiditis, which is infection of the mastoid process, which is part of the temporal bone shown here in this picture. And we'll talk more about this in just a second. Labyrinthitis is inflammation of the vestibular system in the inner ear. It causes symptoms like vertigo, nausea, and vomiting, and this often follows otitis media, and I talk about this in the neurology video on vertigo. Infection can rarely spread into the bones and into the brain and cause intracranial infection, and then many children have some form of conductive hearing loss while they have otitis media. Mastoiditis is a complication of otitis media where the bacterial infection spreads and involves the mastoid air cells, which are found close to the inner ear. These are part of the mastoid bone that are found in the temporal bone, and what you see clinically is a swelling behind the ear, like what's shown in this picture. This is what mastoiditis looks like. It's a painful red swelling behind the ear in a child who previously had otitis media. Any of the bacteria that cause acute otitis media can cause mastoiditis, but the bacteria that have been most frequently isolated in mastoiditis in clinical studies are strep pneumo, strep pyogenes, and Staph aureus, including MRSA. And because MRSA is sometimes found, you have to cover for that when you're treating mastoiditis. As I said, the symptoms are redness, tenderness, and swelling behind the ear. It's usually a clinical diagnosis, but a CT scan should be ordered, and that's because you need to determine the involvement of the bones. This is basically a form of osteomyelitis, and you need to see how much bone involvement there is, and also there's a risk of forming an abscess that would have to be treated. The treatment is with intravenous antibiotics. Vancomycin or linezolid are usually used to cover MRSA, as I said before, and then other broad-spectrum agents are usually added depending on the particular patient's features. And in most cases, if otitis media is severe enough to cause mastoiditis, the child ultimately needs a myringotomy and possible tympanostomy tubes. Now let's talk about otitis media with effusion, also known as serous otitis media. This is a serous fluid effusion that accumulates in the middle ear in absence of any evidence of infection. So in contrast to otitis media, children with this condition do not have ear pain, they don't have fever, they don't have evidence of inflammation. OME often develops after a child has recovered from acute otitis media, so the fever and the ear pain will go away, but they will be left with an effusion in the middle ear. And it's often asymptomatic. If children do have a symptom, the most common symptom is some degree of hearing loss. What you see clinically on exam is something like what's shown in this picture here. You can see there's fluid behind this child's middle ear. You can also see bubbles in that fluid. If you see this, but the child has no symptoms of otitis media like ear pain or fever, then what the child actually has is otitis media with effusion. It's a much more benign condition than acute otitis media. It often resolves with observation. It does not require antibiotics because it's not a bacterial infection of the middle ear. In some cases, tympanostomy tubes are ultimately required so that the fluid will drain and the child's hearing can come back to normal. Now let's talk about otitis externa, also known as swimmer's ear. This is infection and inflammation in the external auditory canal. So that's this portion of the picture here, the portion of the ear canal that's in front of the tympanic membrane, not behind it. It occurs in all age groups of children, but it's more common in the summer among children who are swimming. So the classic history is a child who has been at summer camp for a few weeks and now has symptoms of an ear infection. The main symptom is ear pain, just like with otitis media. There can be itching of the ear and sometimes discharge because the inflammation can lead to fluid leaking out of the external ear canal. This condition can also cause hearing loss, just like acute otitis media. The most common bacteria that cause this infection are shown here. Pseudomonas is very common, and that's because Pseudomonas likes to live in water. So when water gets in your ear, Pseudomonas can colonize the external ear canal. Clinically, the child will have tenderness with an ear tug. That's a classic symptom. You can ask a child who has otitis externa to tug on his or her ear, and the child won't do it because they know how painful it is. You make the diagnosis clinically by examining the external ear canal. It will be edematous and it can be red. This is a picture here on the left of what it looks like. You can see this redness in the external ear canal. That's otitis externa. You can also sometimes see white patchy exudates. This is a picture of that on the right here. There's some white exudate coming out of the ear. As I said, you make the diagnosis clinically based on symptoms and examining the ear, and the treatment is usually with ear drops. These drops contain a combination of antibiotics, steroids, and an antiseptic. The antibiotic is usually ciprofloxacin or ofloxacin. These are the two fluoroquinolones that have good coverage against Pseudomonas. There are also steroids to dampen down the inflammation. And then the antiseptics are things like alcohol or acetic acid, things that just kill bacteria in the external ear canal. Now let's talk about fever without a source. Fever without a source refers to an acute febrile illness with a temperature above 100.4 in a previously healthy child where the etiology or cause of the fever is not apparent based on the history and physical exam. And this is a common problem in pediatrics, especially among babies and toddlers who can't give you a history. Since the child can't talk to you and tell you their symptoms, many times the only presenting feature is the fever and it's not obvious what's causing the fever. Many babies and small children with fever without a source have a benign viral infection that will resolve on its own, but there is a risk that the baby can have something more serious like sepsis or meningitis. And so the decision making in fever without a source is whether or not to do a workup to look for a serious bacterial infection. The management of fever without a source, as we'll see in the next few slides, varies by age. Remember that newborn babies have an immature immune system, and therefore children under 90 days of life are at a high risk for having sepsis, and in these cases, oftentimes a full workup is done to look for a bacterial cause of fever. In children 3 months of age or older, there's a lower risk of an overwhelming bacterial infection, and in some cases in those children, a full workup for sepsis and a bacterial infection is not done. And then once children get to be about 4 or 5 years of age, fever without a source becomes uncommon. That's because those children can communicate, they can tell you their symptoms, and therefore it's easier to localize a source of the infection. So in babies who are up to 90 days of age, there's a high risk of sepsis causing fever without a source that can potentially lead to septic shock. There are lots of possible underlying infections. It could be from the urinary tract, the bloodstream. It can be meningitis. Sometimes it's pneumonia or septic arthritis. It can also be osteomyelitis. And in a baby, infection in these organs and areas doesn't always produce the same signs and symptoms as in older children or adults. So therefore, the fever cannot have an obvious source when you initially examine the baby. The approach for what you need to do in terms of workup varies by how young the baby is in terms of age under 90 days. For fever without a source in a newborn baby that's less than 7 days old, there's a high risk of infant bacterial infection that can potentially be life-threatening. In particular, you have to consider that these babies could have neonatal sepsis or meningitis. Both of these conditions in a newborn baby can present as nothing more than fever and irritability. There often aren't localizing signs or symptoms. So babies less than a week old who have fever without a source are usually sent to the hospital for a full workup that includes blood, urine, and cerebrospinal fluid cultures. This means they need to have a lumbar puncture. And the treatment is with empiric antibiotics. The regimen that's often used is ampicillin and gentamicin, although there are other options. And the idea here is to cover the bacteria that often cause meningitis or sepsis in a newborn baby. Group B strep is one of the most common pathogens. Babies acquire this in passage through the birth canal. But newborn babies can also develop infection with Listeria, Enterococcus, or E. coli, and all of these bacteria are covered by ampicillin and gentamicin. For fever without a source in babies 7 to 90 days of age, the workup varies based on the child's age. The younger the infant is, the more likely they are to be sent for the full sepsis workup we talked about on the last slide. So most babies less than 60 days of age who have fever without a source will get the full sepsis workup with hospitalization and empiric antibiotics. In older children more than 60 days of age, sometimes a limited workup is done either in the inpatient setting or in the outpatient setting. And this varies depending on how the child looks, depending on your preceptor's practice. So in older children, you'll sometimes see this more limited workup done in select cases. For older babies 3 months of age all the way up to toddlers of 36 months of age, the management of fever without a source is based on the child's appearance, and this is a huge thing in pediatrics, determining what the child looks like. Children who are ill appearing are treated differently than children who are well appearing, so you need to learn how to do this on your pediatrics rotations, how to tell whether a baby with a fever is ill appearing. So some of the things you might see in an ill appearing baby are things like a very weak cry or a constant cry that won't stop. Babies that fall to sleep and are difficult to rouse are ill-appearing. A baby who is pale, cyanotic, or has mottled or ashen skin is ill-appearing. Babies with dry mucous membranes are ill-appearing. If the baby has sunken eyes, or it won't smile, or it has an anxious, dull, or expressionless face, all of these things suggest the child is ill-appearing, and those children are treated more aggressively than children who have a fever but are totally well-appearing. They look like a normal, healthy baby or toddler but for their fever. Those children are treated much less aggressively than children who are ill-appearing. And you'll learn this on your pediatrics rotations. Your attendings will emphasize how to tell the difference between an ill-appearing and a well-appearing child. So the reason this distinction is so important is because most well-appearing children have self-limited viral illnesses, and in many cases they can be monitored as outpatients without any further testing. Ill-appearing children are at much higher risk of having occult bacterial infections, and many of these children need a full workup, including hospitalization, blood cultures, and empiric antibiotics. I'll finish with one slide on fever of unknown origin, which is usually called FUO. This is completely different from fever without a source, and don't confuse the two. In FUO, there's a fever greater than 101 degrees for at least 8 days with no apparent diagnosis. And in this case, when the fever's been going on for 8 days, the differential becomes very broad and includes lots of unusual, rare conditions. So some of the things that can cause FUO are unusual infections, things like mycobacterial infections or fungal infections. These can smolder for days or weeks without an obvious source. Autoimmune diseases like lupus or Kawasaki's disease in a child can cause fever for long periods of time. And then lastly, malignancies can lead to B symptoms, so children who have things like leukemia or lymphoma can present with FUO. The first thing to do in a case of FUO is to take a very detailed history and perform a thorough physical exam. Beyond this, many additional tests are possible. Most children get a full laboratory workup, including a CBC plus measurement of a SED rate or the CRP. Blood and urine cultures are usually done, plus screening with chest radiograph and sometimes other imaging. In addition, if those tests don't show anything, many children are checked for tuberculosis and HIV and other rare conditions. And that concludes our module on ear infections and fever.